This is another case of bite imbalance correction. So patient is 33 years and she has a history of TMDs, of ear blockage and tinnitus and jaw muscle stiffness, and intraorally she has been going to dentist and also to me for multiple teeth treatment. She got one tooth root canal and only was placed here. One tooth root canal only was placed here. On see the only. Okay, and I placed an implant on this because the root canal tooth broke one day, and she had got a root canal done about many years back somewhere. Then she had 2 zirconia crowns, and here 2 zirconia crowns were there, but under the zirconia there was a damaged tooth, so we had to remove them and place the implants. So once we placed the implant, before placing the implant, or I don't remember now, but once we placed the implant, we gave her one option that either she was fed up of, in fact she was fed up of one tooth treatment, and the second she gets it done, and third goes like this. The sequence was continuing, and she had TMD. So we said the bite is imbalanced. Either we treat the occlusion or we treat the teeth. So she said she decided for treating the occlusion. So we decided that we will treat it and we'll do the full mouth rehab and we want this to be a canine guided occlusion. So we told her that we'll give you canine guided occlusion. Canine guided means when the canines touch, others don't touch, neither this side or not this side. And when the canines touch on the left side, they don't touch on both sides. So it is interference free occlusion, and the occlusal pressure has to be distributed. Anterior guidance occlusal dynamics have to be considered in canine guided occlusion. So we decided that we'll treat the occlusion. We finished the case. This was initially, and we finished it like this. This is the one we finished. If you see here, the cusp, see this, normal occlusion, the pressure is not distributed. This is a slight space. Maybe some part of tooth is touching here, some part of tooth is touching, but what we want is ideal occlusion. So we have to rebuild and give occlusal locks. Once we give occlusal locks, the hit and slide is reduced. Once hit and slide is reduced, the teeth don't damage. So TMD is automatically corrected or reduced. So this slide is to be reduced. Now we decided that this occlusal lock has to be created. This is the correct occlusion. This is a normal occlusion where there is less hip slide. Slide when you eat, it is slide, but occlusal locks are there. These are occlusal locks. The cusp tips and the canine tips, they create the occlusal lock. And when they wear off like this, see then they wear off, the occlusal lock get damaged, the canine guidance is lost. When the slide is there, all the teeth, multiple teeth touch. See, they are touching here. When it is moving here, they are touching this. So the load is not divided, and one tooth breaks, second breaks, the cascading effect of bite imbalance is there with TMD. Some people have TMD, some people don't have TMD. So we decided to correct the bite, and we corrected the bite and to create the occlusal locks. Now this is the initial, and see this here. We corrected it with composite. Some natural teeth were corrected with composite. So composite against composite, ceramic against ceramic, somewhere Emax against zirconia or Emax. So this is a complex treatment, and multiple things are to be decided, and in multiple phases. So this is a step here, initial. If you see this, then we rebuild it like this. Each and every tooth is rebuilt, and we have created the guidance. See, this is the, now I'll show you this is the original, and this is the final. If you see, this is the original and this is the final. I'll show you on the lower. This is the original and this is the final. So these two are composite. These are composite. Each to this composite build up, polishable, polished, and flossing is done. Can be done in this thing. This is the original, and every tooth is rebuilt naturally and without grinding them. Only those teeth which had crowns or onlays, we changed them. Otherwise, natural teeth were rebuilt with composite. So this is a combination of composite. This you can see the canine. It is composite. So, but we have to consider many factors while rebuilding the occlusion. Canines, the composite against composite runs, and occlusal pressure is distributed. This is the lower, this is the upper. I'll show you here. Upper, this is the original, and this is the final. We had rebuilt it. This is the only hair. We didn't grind the tooth. This is the only hair. You can see. You can see here. Once we old onlay was removed and new onlay was placed on that, because occlusion had to be balanced. And when we balanced the occlusion, we initially placed PMMA crowns for 6 to 8 months. Then we switch over to zirconia crowns. So this patient is in the final stages. We have placed zircon in PMMA crowns for implants, not for others. So wherever there is implant like this here and the implant here, these are PMMA crowns to be kept for 6 months. Once the bite is adjusted, equilibration is done in phases every 2 months, and once the occlusion is established and stabilized, we switch from PMMA to zirconia, layered or monolith depending upon the opposing tooth, or Emax, whatever is required, but multiple. So this has gone from multiple phases, for 1, then 2nd, then 3rd, 4th, 5th and 6th stage, and we finished off at it. So canine guided occlusion is a balanced occlusion where interference free and occlusal locks are treated.